opportunity to listen to so many of our medical colleagues. And so for here today, for the grand finale for this year, we have a talk on diabetes and children and adolescents. So do allow me to introduce our esteemed speaker for today. So today we have Associate Professor Dr. Noor Shafina Muhammad Noor, who is currently the head of Pediatric Department at the Faculty of Medicine here at UiTM, where I work as well. So she's a dear colleague here. She's also a consultant pediatrician and pediatric endocrinologist at our hospital here at HUiTM. She completed her subspecialty training at University Malaya and also the Children's Hospital of Pittsburgh in Pennsylvania in 2015. She's an Associate Fellow of Institute of Pathology, Laboratory and Forensic Medicine, also known as IPERFORM, at UiTM. And apart from that, she's also currently the treasurer for the Malaysian Pediatric Endocrine and Diabetes Group. So it's good to know that we actually have a group. I didn't know that before this. And she's got numerous publications in the international and national journals, books, chapters, as well as contributed in the national clinical guidelines. Her research interest is in the area of pediatric endocrinology, particularly diabetes, obesity, thyroid disorders, and endocrine disruptor chemicals, especially bisphenol A. So she's a dear colleague here and helps us out in a lot of our cases. And we are thankful because now we have, she's also supervising some of our students. So we're really happy to have Dr. Shafina here today to speak to us on this very, very important topic. We will please put your questions in the chat box, and at the end of the talk, I will put the questions forward to Dr. Shafina. I would like to now hand over to Dr. Shafina for her talk.
Assalamualaikum and a very good afternoon. Thank you, Professor my dear Dr. Anna, for the very kind introduction. While I'm trying to share my screen here, I would like to thank the organizing committee, Malaysian Association of Pediatric Dentistry, as well as colleagues from UiTM Dental Faculty just next door to us for the kind invitation. As Prof. Anna mentioned just now, sorry. Alright, okay. As Prof. Anna mentioned just now, yes, we just started our Malaysian MPEDG, Malaysian Pediatric Endocrine and Diabetes Group. It's really just a few months back because now we have more pediatric endocrine in the country. So we are able to have our own group. Where, it is still under Malaysian Endocrine and Metabolic Society and under the umbrella, but we have managed to form our own group under MEMS quite recently. So it is something nice to, it's a way forward. So hopefully we can continue to grow together. All right, okay. So I'm gonna start. Stop me if you cannot see my screen. Anna, is okay, right? My slide?
Yes, very clear, very clear.
All right, okay. So let me start. So as Prof. Anna mentioned just now, it's on diabetes in children and adolescents. I have no conflict of interest to mention here. These are the overview of my presentation. As the title, so I'm going to go through type 1 diabetes as well as type 2 diabetes, but I would also cover obesity topics as well, because I think type 2 and obesity is very strongly related, so it has to be mentioned together. So as introduction, diabetes, as we all know, causes high blood sugar, blood glucose levels in the blood. And it occurs not only, it is a disease in adults, but also it is a disease in children. And the two most common types of diabetes in children and adolescents are type 1 and type 2 diabetes. In adults, I'm sure we all know type 2 is the most common, but in pediatric population, type 1 is still the most common diabetes affecting our children. Yes, as I mentioned earlier, and although we mentioned that type 2 is not as common as in adults, but it is increasing and becoming an alarming public health concern among pediatric population. And the reason being that this is contributed by the increasing prevalence of obesity worldwide. So hence, I hope to end my session later on by talking on obesity as well. These are the diagnostic criteria for diabetes. If you notice, it is the same definition for adults, and pediatric population is using the same definition as well. So there are four criteria. One is if random plasma blood glucose is more than 11.1 with symptoms, or you have a fasting blood glucose more than 7 millimole, or sometimes we would have perform an oral glucose tolerance test, your sugar load test, and that is also 11.1. And the most recent criteria which has been added is HbA1c of more than 6.5. But bear in mind, if if the patient has symptoms of diabetes, you only need one reading of blood sugar which is above these ranges to diagnose the patient to have diabetes. However, if let's say, from history taking, your thorough history, the patient denies any symptom, the patient or the parents deny any symptoms, you need at least one more readings to say that this is diabetes. So you can't rely on one reading if they don't have symptoms. All right, so let's go on to talk about our type 1 diabetes patients. The pathogenesis is characterized by chronic immune-mediated destruction of pancreatic beta cells, which leads to either partial or absolute insulin deficiency. So there's insulin deficiency in type 1 diabetes, and it is autoimmune. When you take bloods, you would send the bloods for autoantibodies, and a patient with type 1 diabetes should have positive autoantibodies. There are several autoantibodies available. Usually it's sent to either IMR or Gribbles. You only need one positive autoantibodies to say that this is autoimmune in nature. Although the etiology, although we say this is autoimmune, but the actual etiology is still multifactorial, and however it is still remains not so clear and to date. Incidence varies, obviously. Depends on where the patient resides, and as well as the country of origin, as well as the ethnic population. So it does vary greatly. As expected, the highest incidence would come from countries from your Caucasians, Finland, Northern Europe, Canada has the highest incidence. Of the estimated approximately 500,000 children with type 1 diabetes, and 22% are from North America and the Caribbean region. So as you can see, more than about half of the population comes from these two regions. What about in Asia? The incidence of type 1 diabetes is lower compared to the countries we mentioned earlier. The countries who has reported their incidence include Japan, 2 per 100,000, China 3 per 100,000, Taiwan 5 per 100,000. What about in Malaysia? Unfortunately, we only have data dating back to 2008. So this is the publication from our diabetes registry, which managed to register 240 patients, both type 1 and type 2. And these two groups of diabetes showed type 1 diabetes is the most common, almost 70%, and with 17.5% were type 2 diabetes. So hopefully we will have our, because DICARE or the registry is under improvement by our ministry. So hopefully we will have the updated version and we'll be able to feed our data into this. Then definitely we do have more than what it is registered, and that's one, because this obviously the registry depends on, if you register it will be captured, if it's not registered it's not captured. So that's the bias there, as well as this is more than 10 years ago, so hopefully we'll have more data later on. Talking about symptoms of diabetes, I'm sure all of you would have known, but just to recap, this is a nice poster from Diabetes UK. They have been promoting, like educating in terms of 4 T's. What are the T's? Which are the symptoms of diabetes? Number 1 is toilet, whether they are having, they're going to the toilet to pass urine more often, tired, lethargy, tired, thirsty, whether they're drinking more often, and thinner, whether they are losing weight. And this has been quite successful over there in terms of educating not just parents, but as well as medical profession. This is what we mentioned, the early, let me see, okay, the early, I'm going to try and see if I can get the laser pointer. All right, okay. So these are the early symptoms we mentioned just now, part of the 40s, polyuria, polydipsia, weight loss. And I would like to highlight this as well. I mean, like in a patient or a child who has been dry by night, not wearing pampers whatsoever for many years, but suddenly parents came back and concerned that the child is bedwetting again. So maybe we should be aware that in case that's one of the symptoms of diabetes as well. So it's kind of like a red flag that you have to investigate that, so that you're not missing diabetes. And next is the, if you see there, is the late sign. Late sign, what do we mean by late sign? Because these are mostly the signs and symptoms of diabetic ketoacidosis. It's a complication of diabetes. If it's not detected early, the patient will, with type 1, will go into diabetic ketoacidosis, and they can be very sick with it. So it is, the symptoms include vomiting, dehydration, abdominal pain, rapid breathing, hyperventilation, and again, they can come in quite, if they come in quite late, they can be drowsy, and also coma with reduced GCS. So we don't want to catch them at this late stage. So having said that, obviously awareness is important, not just for parents to detect all these symptoms so that they could come for advice, but as well as that we would like our medical professional, our health professional, to also be aware, because if you see these are really not specific, I'm like a child who's vomiting, sometimes you wouldn't be thinking of DKA in a patient newly diagnosed. If the patient already have diabetes type 1, perhaps they would know that this is one of signs of DKA, but it's a newly diagnosed, sometimes it can be missed, not just in a small hospital, but sometimes in a big hospital as well. So increased awareness of these symptoms is important. So as I mentioned just now, DKA, despite increasing awareness, but high number of newly diagnosed type 1 diabetes in children still present with DKA, unfortunately. And of course, the rate of DKA at the onset, the first onset of type 1 diabetes, ranges from 15 to 70% in Europe and North America. If before this is the publication from Malaysia, the one I've shared earlier. If you look at Malaysia, comparing with Malaysia, from the previous this old publication, 57% of our newly diagnosed type 1 diabetes children still present with DKA, so which is still quite a high incidence to compare. So obviously in countries which, for example, in Finland, we mentioned Northern America, for example, usually the rate of presentation of newly diagnosed diabetic with DKA is lesser compared to this part of the region, whereby you have a lesser incidence of DKA because people are not quite aware about the symptoms, for instance. All right, okay. Yes, I mentioned this earlier. What about the morbidity and mortality of DKA? Mortality rate from DKA is 0.15% to 0.3%. The main cause of morbidity and mortality is the cerebral complication. Among the cerebral complications, cerebral edema is the most common cause of DKA. Cerebral edema is the most common cause of cerebral complication in DKA to date. I just want to share this one publication from our team, whereby we reported a case of a girl who was recently diagnosed with type 1 diabetes. She presented with DKA, of course, and then later on she developed expressive aphasia as well as hemiplegia around 48 to 72 hours post commencement of treatment of her DKA, and later on she was diagnosed with ischemic hemorrhagic stroke. So we just highlight that although we mentioned that cerebral edema is the most common cause of cerebral injury in patients with DKA, but we do have to think of other complications, not so common complication of DKA, which is what they can have ischemic or hemorrhagic stroke as well. Hence, we highlight the importance of close neurological status monitoring in this group of patients who present with DKA. Okay, so moving on to treatment of patients with diabetic. Type 1 diabetic particularly. If you see, these are the different types of insulin. So if you remember the pathogenesis of the type 1 diabetes, because they have insulin deficiency, so hence what we're trying to mimic here is to replace the insulin deficiency that the patient has, and thereby by supplementing external insulin for the patients. And on top of that, the glycemic control of the patients need to be improved by doing regular SMBG or self-monitoring blood glucose measurement, because by knowing what is your blood sugar level at that particular point in time, hence you would know whether you would need extra or lesser insulin requirement, and you would be able to adjust the insulin doses. Hence, this goes hand in hand together in our patient. And there's of course in diabetic, there's a lot of new technologies coming in, and what you see here in this picture is just one example of the insulin pump. What you see here, this is a small equipment of insulin pump. Inside here, there's a insulin reservoir. So if you imagine the reservoir inside here, it will be kept inside this small machine, and the insulin will be will go along the tubing and will be distributed under your subcutaneous tissue, and if some of the machine as well can, if you have this is the glucose center that the glucose sensor, which can feed you the blood sugar levels of the patients over 24 hours. But usually the use of insulin pump is usually restricted by the cost of the pump itself, but not only the cost of the pump, but this tubing has to be changed every 3 days, every 72 hours, and you have to factor in the cost of this as well. So that's why most of the time our patients might not be able to afford it. All right, okay, so moving on, why are we so obsessed on having control glucose range in our patients? Because the better the glycemic control, the lesser complications of diabetes our patient is subjected to, is at risk. So this is just a cartoon representation. Of course, you know the complications of diabetes, whether it is macrovascular or it is microvascular. You have your retinopathy, nephropathy, you do have your neuropathy, as well as your heart and stroke complications and so on. So that's why usually if, let's say, the patient has started to be diabetic from the age of 7 or 8, for example, if their diabetic control is not good, you don't want to see them having to have dialysis at the age of 20 something. So that's why we try to aim for a good glycemic control in our patients. All right, I just want to share some of our data. This is still unpublished data, but we presented the paper at our conference a few years back. Actually, Zaki is one of our medical students who graduated. So we look at the diabetic nephropathy among adolescents with type 1 diabetes, since we're talking about complication. In the paper, so we have different ethnic groups, and the mean age of this population is 15.3 years of age. And diagnosis, mean age of diagnosis was 8.8. So what was shown here, that among this population, we have 10.1% patient who has nephropathy, and if, as expected, those who has higher HbA1c would have higher risk of having diabetic nephropathy. So that's why we would be very vigilant on monitoring HbA1c level to keep it within range to avoid this complication. So what we concluded was they may exhibit earlier changes of diabetic nephropathy. Poor control is a contributing factor, and hence intensive education and treatment may prevent or delay the onset. And obviously, consistent screening should be performed to prevent the progression to frank proteinuria. All right, okay. So that was what I wanted to talk on type 1 diabetes, the most common diabetic in children. Moving on to type 2 diabetes. What is type 2? This is when insulin secretion is not sufficient to meet the increased demand posed by the insulin resistance, hence leading to relative insulin deficiency. So they are still able to produce insulin, unlike our type 1 diabetic patient, but because of the insulin resistance, the tissue is becoming less sensitive to the insulin available. The effect would still be the same, whereby their blood sugar level will still be high. And generally, it is associated with other metabolic abnormalities, characteristic of insulin resistance, dyslipidemia, hypertension, polycystic ovary syndrome, and fatty liver. Today's study is one of the landmark study in type 2 diabetes in children and adolescent. The study found out that the rate of beta cell function deterioration in children and adolescents type 2 diabetes is actually significantly higher, whereby 4 times higher than in adults. So that's why it is quite worrying to note this from the study. And about 20 to 35% decline in children, adolescents, compared to only 7 to 11% deterioration in adults. And children and adolescents with more advanced disease at baseline may experience progressive and more rapid loss of beta cell function and were unable to maintain satisfactory glycemic control. So from this study and a few other studies as well, we know that we have to be more aggressive in treating our type 2 diabetic children and adolescents. You are being aggressive with adults, but of course we have to be more aggressive with treating children as well. What are the risk factors for type 2 diabetes? Number one is, of course, the genetic plays a big role in type 2 diabetes. And of course, being Asian is not helping as well, because being Asian is already one of the big risk factors for diabetic type 2, and as you know, being in Malaysia, of course, adult with type 2 diabetes is so common. Somebody in our family members will be will have diabetes, from our side or from our mom's side, of our dad's side. Definitely, I can assure you. So that's why it is quite common, and we have to be careful in this. It is coming towards our children as well. And apart from genetic, environment is also a big contributor, whereby the number one is nutrition. You have obesity and inactivity. As you can see, nutrition and inactivity definitely contribute to obesity. So these are all the risk factors to be put forward when managing a patient with type 2 diabetes. Same complication, like I mentioned earlier, complication of type 1 diabetes and type 2 diabetes are similar, but the difference between type 1 and type 2 is a child who is diagnosed with type 2 diabetes, the screening for complications should start at the time of diagnosis as compared to type 1 diabetes. Why is that? Because usually with type 2 diabetes, you might not know that you have diabetes until a few months later, until years later maybe, because sometimes the symptoms can be quite subtle as compared with type 1. Usually they may, they have symptoms 1 week, 2 weeks, and then they go into DKA, they get very sick, they come to the hospital. But with type 2 diabetes, they may have diabetes for many months before they come in to the medical attention. So that's why the complication screening starts at diagnosis for type 2 diabetes. Again, today's study mentioned that children and adolescents suffer from the same complication, like you mentioned. However, the progression of the comorbidities is faster compared to adults. Hypertension increased from 11% to 33.8% after almost 4 years of diagnosis. Microalbuminuria increased from 6.3% to 16.6% after 3.9 years, as well as lipid disorders has been reported to be more common in children and adolescents with type 2 diabetic. So not only they have progression, the deterioration of the beta cell function is faster, but also all this complication comes in at a faster rate as well, which is worrying. Presentation, definitely almost the same with type 1 diabetes as we discussed earlier. Patient usually can be symptomatic. The symptoms are similar like we discussed just now. If it is quite severe, they may also present with DKA. I mean, historically, before this, we say if the patient presents with DKA, there is definitely 100% type 1 diabetes, but that's not the case now. We know now that type 2 diabetes also can present with DKA. As well, so that's why it's not as easy to differentiate between these two, type 1 and type 2 diabetes. Non-classical can be in a form of infection, pruritus bulba, UTI, or skin abscesses, and they may be asymptomatic, like we mentioned just now, and it's just incidental findings from screening your blood sugar, for example. The same, so I'm not going to go through one by one. Diagnosis, these four criteria remains the same for type 1 and type 2. And like I mentioned earlier, in the absence of symptom, must be confirmed with another reading on subsequent day. This is from the Malaysian, sorry, I forgot to reference it. This is from the Malaysian Pediatric protocol. Nicely outlined the difference in the clinical features between type 1 and type 2 in children and adolescent. If you see here, type 1 diabetes is usually younger, can occur from as young as 6 months or to young adulthood. However, with type 2 diabetes, it is usually around pubertal age or slightly later. So they usually, that's the usual presentation, but because of the prevalence of obesity, we do tend to see that the age for type 2 diabetes is getting slightly younger over days. The clinical presentation, usually acute, rapid onset of symptoms, a week or 2 weeks of symptoms, and then if not detected, they go into DKA. So it's quite rapid as compared to type 2 diabetes, more insidious onset of symptoms. So they may have that for a few weeks or months before diagnosis. Autoimmune, type 1, yes. Type 2 is not autoimmune in origin. Usually, they have ketosis for type 1 diabetes. Ketosis can range from ketonuria or ketonemia, depending on what you have at your center. Body habitus. In type 1 diabetes, they are usually lean. They not overweight or obese, but because of the increasing prevalence of obesity, now you are seeing, even though type 1 patients are becoming on the overweight side as well. Compared to type 2, usually they are overweight or obese. Acanthosis, I have a picture of it in my next slide, I think. Type 1, usually it is absent. Type 2, commonly present in type 2 diabetes. Acanthosis nigricans is a sign of insulin resistance. It's a skin manifestation of and a sign of insulin resistance. Sharing another poster that we presented many years back is a patient in which we saw. This is an interesting case where initially the patient, this is an Indian patient who's overweight. And of course, with the overweight, and he does have the acanthosis nigricans on his neck and axilla, we diagnosed him as type 2 diabetes and started him on treatment for type 2 diabetes. However, usually with all the patients, all the children and adolescents with diabetes, we would send insulin autoantibody to make sure that we're making the right diagnosis. And when the results came back, he has positive insulin autoantibodies in the thousands. Hence, we had to revise the diagnosis to type 1 diabetes and started him on the full basal bolus insulin regimen with the diagnosis of type 1 diabetes. So the diagnosis between type 1 and type 2 is not as simple as we thought previously. I mean, like previously when a child is thin, definitely that is type 1 diabetes. If they're obese, the type 2 diabetes. But because of the trend now of having more obesity in the population, the diagnosis is not as simple as before. Hence, we may need help, not just history and the clinical examination, but we do need help from laboratory investigation, for example, the antibodies and so on, to help us to make the diagnosis, because the treatment differs between the two types of diabetes. This is a picture of acanthosis nigricans on the neck of a patient, and this, apart from the neck, it can manifest in the axilla as well, and sometimes at the knuckles area of your hands as well. And I suppose you do see sometimes promotion on different kind of soap to hilangkan daki, for example. So this is not daki. So I always tell my parents, my patient, that even though you have like I don't know, some kind of brush or some special brush or something, this is not going to come out unless you try to improve your weight, as well as increase your activity, improve the diet, and so on. That would lessen the appearance of the acanthosis nigricans, because this is a sign of insulin resistance, or this is a pre-diabetes state that you want to catch early before they go into full-blown diabetes. All right, okay. Just sharing one publication from my colleague from this is just recently reported in 2021, whereby they look at the misdiagnosis, whether it is common or not, from their population. About 38.7% type 1 diabetes will be initially misdiagnosed as other things, and the misdiagnosis is usually more common in the younger children compared to older children. As you can see here in the figure on the right, most misdiagnosis is they were diagnosed as respiratory problem. This is maybe, if you remember, the one of the sign of DKA is rapid breathing. So they may thought the child has asthma. The emergency department might just give a nebulization to the patient and then send home. Gastro problem, they present with vomiting, so they think that the patient has acute gastroenteritis. So maybe they just hydrate, give fluids, and then again send home. Infection, again with AGE, gastroenteritis, they may thought that this is some kind of bug, abdominal infection, so send home. So these are the things that even surgical, maybe they thought of, because of the abdominal pain, they might think that this could be gastritis, or they may think that this is appendicitis, for example, referred to surgical, for example. So these are the things that this is not just in small hospitals, sometimes in big hospital as well, we do see the different diagnoses being made. So be aware, be vigilant. Is as simple as checking your DXT. That can give you a lot. At least you can rule out that you're not dealing with DKA, newly diagnosed diabetes. All right, okay. So we mentioned, I mentioned just now about pre-diabetes. The American Diabetes Association has designated this physiologic state of pre-diabetes, especially to recognize the high risk for progression to diabetes in adults. So what the classification outline, remember just now, if we have the diagnosis for diabetes is sugar, fasting sugar more than 7 or more, so in fact, fasting glucose or IFG is when your fasting plasma glucose is between 5.6 to 6.9, and as well as your fasting, you also have impact glucose tolerance, whereby after your OGTT, your blood sugar is between 7.8 to 11.1. So that's why you want to catch this pre-diabetes state, so that you hopefully you may prevent the patient from becoming a full-blown diabetic in the future. And A1C between 5.7 to 6.4% is another classification for pre-diabetes. So it's quite common. So the thing is just we need to get it checked, because it's just, hopefully that we may prevent progression into diabetes. This is just a diagram on the management for type 2 diabetes in children. The main, of course, the main treatment still involves diet and lifestyle modification. But if, let's say, your HbA1c is less than 8.5, and you have no symptoms, the treatment is oral, starting with oral medication. Oral medication, which is registered or licensed for pediatric population, is still metformin. Adults has many types of oral medication or oral hypoglycemic agent, OHA, but in pediatrics we still rely on metformin alone as the oral medication. If the HbA1c is more than 8.5%, you cannot rely on metformin alone. You need insulin treatment to get on top of the metformin to ensure your sugar is well controlled. Because with HbA1c of 8.5, definitely the glucose profile is not good in this patient. And if later on the patient is improved, of course we aim to reduce and stop the insulin and maintain on the metformin alone. However, if after metformin alone the patient is not having good glucose control, HbA1c is not improving, remember the target is less than 7% HbA1c, you have to add on the basal insulin back again into the treatment. And again, if with the basal insulin to a certain dose, up to 1.5 unit per kilo per day actually, if that doesn't improve, doesn't reach your target, the addition of prandial insulin, meaning basal bolus like your type 1 diabetes, should be administered. So that is the flow for the management recommended by ISPAD. The latest guideline was in 2018. ISPAD is the International Society for Pediatric and Adolescent Diabetes, and the guideline is available online for free. We mentioned metformin and insulin being the type 2 diabetic treatment. What about other agents? Adults have more agents, but unfortunately in pediatrics we have restricted options. But 1 year ago, liraglutide has been licensed, approved in children and adolescents with type 2 diabetes. But this is also an injection, subcutaneous injection, and I haven't had the experience of using this in my patient yet. Obviously, might be restricted with cost and so on. But this is something new. One option that may be available there as compared to before this, we only have metformin and insulin alone. I have since this a lot of participants here from the dental fraternity, as Prof Anna mentioned just now, I'm privileged to be supervising one of the master student in UiTM dental faculty. So currently Zarida is doing her project on looking at patients patients with children and adolescents with diabetes in our center as well as in University of Malaya, and looking at their periodontal health status. So at the moment we are still collecting data, and because of COVID and so on, I think it is somehow delayed, but we are catching up. So hopefully we will have the data soon. But having said that, she has worked so hard and coming up with a systematic review and meta-analysis, and this was recently published this year in Australian Dental Journal. What was included in this review was 11 total articles were included, and this looking at patients with type 1 diabetes mainly. There's some type 2s as well, and the participants' age were from 4 to 18 years of age. And what was the conclusion was plaque index, gingival index, clinical attachment loss, and periodontal probing depth were significantly higher in diabetic children compared to non-diabetes, and early detection of diabetic children with parental disease is crucial. Don't ask me more than this. Maybe I have to get help from Dr. Raida or Dr. Ernie to come in to answer your questions. But hopefully we'll have more data once she finish her project, hopefully. Okay. Okay, I have some more slides just to finish off on obesity. Now 1:44, maybe another 5 minutes before we go on to Q&A. I'm going to skip this. Epidemiology, it is increasing in trend. As we mentioned, this is in the States, reported to be as high as 17%. Recent reports show that this is increasing in trend, most prominent in adolescents age group. And what about in Malaysia? Adults, okay, I'm just sharing adults. 1 in 2 adults in Malaysia were either overweight or obese, and 1 in 2 as well have abdominal obesity. This is also in adult population. In Southeast Asia, we are number 1, and number 2 is Thailand. So we are the champion in Southeast Asia. And what about in Malaysian children? Malaysian children, we are not far behind. We are number 2 behind Brunei. We are the 2nd highest in Asian in childhood obesity. So we don't want to be champion in this area. And there's another study in 2014 whereby 13-year-old adolescents, 1 in 4, I would say 25%, either overweight or obese. So this is worrying. This is a diagnosis. Just to highlight here, we still use BMI in children, but BMI with the same formula being used, but in children, the absolute number means nothing much to us. What we need to do is plotting the BMI on this chart, whether this is a boy or girl according to their age, and then we see where it is on the chart. We would know whether the patient is obese or overweight. So this is what I meant. And as an example, above the 85th line here, this child, if you plot it, if it's plotted somewhere here or here, the child is overweight. And if this is plotted above 95th centile, for example, if you get it here, this is obese. The child is obese. So if you imagine, if the child is a bit younger, maybe a BMI of 20 is for adult is fine, but in children is already above the 95th centile. So that's why we have to plot it on the centile before we can know further. All right, comorbidities, the same with your diabetic as well. So I'm not going to go through. So that's why prevention is very important to reduce the risk of complications. When we talk about complications and all, we managed to went on to look at whether parents have the right perception of their children's weight status. So interestingly, what we found was a quite high percentage of parents whose child were either overweight or obese think that their child has normal weight. So this is 50% plus and 80% plus. So what it tells us that most parents have inaccurate perception of the child body status. So if you don't have the right perception, of course you wouldn't be getting extra help in terms of getting seek medical advice, for example. And this is the sociodemography, depending what we found. I'm going to skip this. Insulin sensitivity, insulin resistance. So this is the two term to see whether when we're dealing with obese, prediabetes, and type 2 diabetes. Hence, sometimes because we cannot measure properly, so usually we use markers to introduce whether the patient has insulin resistance or not. And these are examples of markers to check whether the patient has insulin resistance. For example, just sharing one of the publication that we did to look at different markers of insulin resistance. I'm going to skip this. Metabolic syndrome, this is my last topic. Metabolic syndrome, it is currently recognized as a major public health concern. It represents a clusters of risk factor, dyslipidemia, hypertension, central obesity, hyperglycemia, insulin resistance. And this is the diagram. So you must have visceral obesity plus 2 or more of this risk factor to say that you have metabolic syndrome. So in summary, diabetes occurs not only in adults, but also in children and adolescents. Type 1 diabetes is the most common diabetic in children. However, type 2 is also increasing in trend. Obesity prevalence is increasing, and this necessitates urgent detection and prevention to reduce the risk of future complication. With that, I thank you. Anna, back to you.
Thank you, Prof. Shafina. I think that was really, it took us through type 1, type 2, and I think it was really important that you highlighted obesity as well. I was very interested when you highlighted about the misdiagnosis. And I think there's a role that we need to play as well, because you were talking about the signs. Basically, it doesn't matter whether it's type 1 or type 2. We should be picking up some of these signs as well, because sometimes the patients show up to us, and especially in type 2, which they're developing later, and with obesity. And I think it was very interesting when you said that there's wrong perception among the parents, because for dentistry, we tend to see patients with obesity, they present with caries as well, because a lot of them are mouth breathers. They do have some form of OSA at some point. And I've had my own experience of trying to speak to parents to very gently say that maybe I would like to send the patient for some evaluation because the BMI is high. Yes. And the parents are quite annoyed when we suggest. But I think when you highlighted this, I think it's important for us to actually refer our patients. And simple dextrose take, you were saying that, a simple test, and I think we should be screening, since we are champions of obesity in Southeast Asia. I think it's also a responsibility to send some of these patients for screening. And
yeah, and definitely, I mean, like, I was brushing through the results of where parents had the wrong perception, right? So I mean, like, if you don't have you don't perceive your child to be overweight, perhaps, so of course you're not gonna seek medical attention, like you mentioned. And sometimes in denial as well. So we do find patients in our clinic, for example, which has been referred, and the parents do come, which is really good, but in the end it'll be like itulah doktor, dia tak jaga makan, dia tak apa. I mean, like, it's kind of like blaming game there, but you're there in the clinic thinking that the parents are like twice the so it's kind of like you kind of have to it's a whole family punya intervention lah, I suppose, in terms
Yep.
of changing the lifestyle modification as a family, kan, because it's unfair to just blame put everything just for the patient, kan, not just the whole family had to change lah, I suppose.
Yes, I think it's motivation. Being a patient myself, I can say that it's actually very difficult.
Yes.
And you feel guilty. And I think that there's a lot of motivation, especially when it comes to a child. I've got another question here. It's, because as pediatric dentists, we take a lot of our patients for treatment under general anesthesia. And so for many different types of treatment, most often it's for comprehensive dental treatment, which usually we don't have to give, any extra medication and things like that intraoperatively. However, we do have cases of surgery. Sometimes we have some extensive surgery or some trauma. My question is this: if it's going to be a long GA for a patient who is diabetic, is there any precautions? Because would we be worried about any hypo or things like that that could happen intraoperatively?
Oh, yes, thanks, Anna. Good question. Definitely patients who's diabetic, and especially if they are on insulin, we do recommend, or they have to be admitted in the hospital before, because we have to titrate their insulin. Usually they need to be put on IVI insulin, because especially if the surgery is going to take a long duration of time. So definitely we have to convert them into intravenous infusion of insulin rather than their basal bolus, because that will help our anesthetic colleague to play around with the insulin dosing, the rate of infusion, to make sure that blood sugar is within the control throughout the surgery. And after the surgery, because after the surgery the child would be they won't be able to eat right after, because of the anesthetic. So definitely they will be on the infusion for some time before they are and then when they wake up and then they wanted to eat and drink, then we can convert them back into their usual basal bolus regime. So don't hesitate to contact one of our team to advise and try to improve the sugar control for the procedure and after the procedure. Yeah.
Okay. Do I see any other questions? Am I not seeing? Is there any other questions from?
And interesting, you mentioned about you were saying obese patient and then they have caries and so on. So that's quite interesting. And with the OSA, obese and OSA goes hand in hand. Yeah, so that is really interesting. Yeah.
So a lot of them, when you speak to them, they will have to adjust their pillow because breathing becomes, a little bit more difficult. And so what happens is sometimes the mouth is open, so it tends to get dry faster. So we do pick up a lot of these cases, and you can see. So usually we would like to screen, but now I think you've highlighted that perhaps we should send, because I think for pediatric patients, when they go for a general checkup, they hardly do a glucose. They hardly test for diabetes.
Yeah.
Even pressure, for that matter, not all the time they take. So I think it's quite interesting that we need to point out. I mean, I didn't think of this before, but I think now I'd make it a point that if we do see these patients, no harm in sending them for an assessment. Okay, if there are no other questions, I would like to thank you so much, Prof. Shafina. It's been really a good session, and I think it's the first time we've had a discussion on diabetes, and I think
my pleasure.
Yes, and it's a lot, as you said, there's a lot of collaboration to go on. We're so happy that you're collaborating with our department as well, with Dr. Rohaida, Dr. Annie, and I think it's a long way, and I hope that we will continue to have a lot more input regarding diabetes. Okay, with that, I'd like to thank you. Thank you to everyone for attending today. Happy New Year, Merry Christmas, and join us next year, because I'm sure we'll have a great lineup for you next year. Thank you, everyone.
Happy holiday.
Thank you, Shafina, for agreeing to.
Thank you. Thank you, Raja.